Florida's beautiful 16th Congressional District for Health Subcommittee hearing. And talked to quite a few of the members up here. They're interested in taking a look at this. They want to see if they can get a place here as well. So I'm thrilled. I mean that personally. I'm thrilled to hold this important hearing focused on prevention and healthy living. As I speak about often, Americans spend more dollars on health care than any other nation, yet our country is getting sicker. We spent over $5 trillion, not billion, but $5 trillion on health care, yet 6 in 10 Americans have at least one chronic disease. Chronic disease like diseases, the diabetic, cancer, obesity are the leading causes of death in our country. When we look at the obesity rate, about 20% of children are obese. Compared to in our generation, it was 3%. That's shocking to me because a lot of times you can't, as many of you know, the doctors, if you're overweight and everything when you're young, that follows you a lot of times. 30% of adults are obese, disqualifying them from military service, those from, let's say, 20 to 30, and at least 40% of adults are obese. So obesity is projected to result in as much as $9 trillion in excess medical expenses. We must think about health care in this country differently. Patients and taxpayers are depending on it. We must train the next generation of doctors, and they do such a great job here, but it's really critical to prevent chronic diseases and focus on nutrition and healthier lifestyles. We must also support a healthcare system that values prevention, not reaction. Instead of fee-for-service, we need to have something based on outcomes and values. I believe new technology will also play a key critical role on that in terms of prevention. Ultimately, I want people to be the CEO of their own health. I look forward to highlighting how my congressional district is supporting prevention and healthy living. I look forward to discussing ways to improve the health of Americans. I'm pleased to recognize the gentleman from Nevada, Mr. Horsfield, for his 5-minute remarks in his opening statement.
Well, good morning, everyone. It's great to be with you. Thank you to Chairman Buchanan for welcoming us to your beautiful home here in the 16th Congressional District of Florida. I'm from Las Vegas. I don't think we could ever have a congressional hearing outdoors in Las Vegas. But I wanted to be here out of respect for you, Mr. Chairman, for the subcommittee on healthcare and your work on so many important issues to improve healthcare outcomes. And also because I think it is important for us to speak with one voice, Republicans and Democrats, that we believe a core message that America should be healthy. In fact, that is why members of this committee on both sides of the aisle have long championed this goal. We may not all agree on exactly how to get there, but having the core mission of making America healthy is absolutely something that I support. 16 years ago, we drafted, debated, and passed the most significant expansion of healthcare coverage in our nation's history, the Patient Protection and Affordable Care Act. The ACA opened the doors of our healthcare system to young adults, the working poor, small and independent business owners, and people with pre-existing conditions who were told that they would never have access to coverage. Moreover, it ensured that preventative care was within reach, care that has saved countless lives and made millions healthier over those 16 years. But since the beginning of the year, the promise of accessible, affordable health care is slipping out of reach for far too many Americans. Take Miss Priscilla Brown, a 48-year-old truck dispatcher from Orlando, living with type 2 diabetes. Like millions of others, she is enrolled in the Affordable Care Act marketplace and relies on daily insulin to stay healthy. Yet rising healthcare costs have pushed her into a situation that no one in the wealthiest nation in our world should face. Some days she takes only half or even a third of her prescribed dose in order to stretch it out. Other days she skips it entirely. not because she wants to, because she has to, in order to afford the ever-increasing cost of basic living necessities while balancing her new premium monthly expenses. Now, Ms. Brown's story is heartbreaking, but it is not unique. New data from the Kaiser Family Foundation shows that roughly 8 in 10 Americans who re-enrolled in the Affordable Care Act marketplace this year are facing higher healthcare costs. And for about half of them, those increases are substantial. Now, we all can agree that there's more work that has to be done. No bill is perfect, and that is why the Florida Policy Institute estimates that 1.5 million Floridians are projected to lose their health care coverage, and that is one of the reasons that I'm also here today. On top of the pre-existing 14.8% of Floridians who are already uninsured. So I look forward to hearing the testimony from our panelists today. Thank each of you for your expertise, for your education, for your background, and for focusing on a wellness care system, not a sick care system. And if we all can work towards that goal of improving health care, we can make America healthy again. So thank you very much, Chairman, for allowing me to be here with all of you today.
And thank you. Now I'm pleased to recognize the chairman of the Ways and Means Committee, Mr. Smith, for his opening statement. And he was one of the mentioned how lovely this area is, being from your part of the world.
I love my part of the world, but this is very, very lovely weather. Thank you, Mr. Chairman. It is great to be here in sunny Florida and to hold our second committee hearing outside, which is good. The Natural Resources Committee could learn from our work. We're glad to be here today in Vice Chairman Vern Buchanan's congressional district. Chairman Buchanan is one of the strongest champions for chronic disease prevention we have in Congress. In fact, Vern was on a mission to make America healthy again way before it was cool and people started talking about it. We will miss him in Congress. We'll miss his leadership on this topic, but we still have 8.5 months to do a lot of work and hopefully get some things done. I also want to thank our host right here, Lake Erie College of Osteopathic Medicine. This school is one of the 53 medical schools that joined the Trump administration's pledge to provide at least 40 hours of nutrition training to students. Educating our future doctors on good nutrition is critical for the patients who will one day trust them for medical advice. The Nutrition Pledge is a recognition that not enough attention and resources have been paid to prevention in our healthcare system. Today, that system incentivizes treatment of chronic disease over its prevention. That reality is simply not working. Despite our nation spending an astounding $5.3 trillion on healthcare each year, 60% of Americans still have at least one chronic disease, heart disease, diabetes, or cancer, all of which disproportionately affect rural Americans, who I represent. For Medicare beneficiaries, that number is a staggering 95%. That statistic should not be a surprise when Medicare only spends 5 cents of every dollar on primary care. Too often we intervene only once someone has gotten sick and do too little to stop Americans from getting sick in the first place. That is why the Ways and Means Committee passed legislation that encourages more preventive care, like providing multi-cancer early detection screenings to seniors on Medicare. The Working Families Tax Cuts expanded HSAs to millions of more Americans, which allows individuals to invest in their own health and wellness. The Rural Health Transformation Program is investing $50 billion in efforts to grow and sustain innovative care in rural communities. But that is just a start. More has to be done to help Americans live longer, healthier lives. Medicare could expand value-based payments to improve patient outcomes while reducing the cost of wasteful medical services. More patients could receive new innovations in disease testing and care delivery to detect disease before it is too late. Doctors could show patients realistic ways to take care of themselves, like spending more time outdoors, like we are here today. I want to thank each of our witnesses for taking time away from your practices to share your experience of what is working and what is not, and your ideas you have to modernize healthcare for the benefit of all Americans. We also want to hear from everyone in the audience who took time to come today. There will be clipboards passed around during the hearing right over there. They'll be passing around for you to share with the committee how preventive care has made a difference for you or a loved one, or share other thoughts about today's hearing topic. These comments will be entered into the official record for this hearing. I want to thank you again, Mr. Chairman, for having us.
Well, thank you, Mr. Chairman Smith. At this time, I'd like to recognize my neighbor and friend from Florida 17th Congressional District, member of the Health Subcommittee, Congressman Stubbe, for 1 minute.
Thanks, Mr. Chairman, and thanks for having us. It's awesome to be at home and have a congressional hearing. I grew up like 15, 20 minutes from here. My district's just south. It's great to be back in Southwest Florida. I want to thank all of you that do great things to make this area great, and I look forward to the testimony and the questions. So thanks for being here.
Thank you, Mr. Stubbe. I'd like to recognize our other member from Florida delegation, Congressman Bean, for 1 minute.
Thank you very much, Mr. Chairman. Very good morning to you. Good morning, Ways and Means Committee, and what a big deal it is to have you here. Ladies and gentlemen, you're here. You'll always get to say, I was there that day they met on the porch. And if you're not wearing a hat, you should. My mom will tell you, protect your skin. That's a little bit of health knowledge right there. For my colleagues that have traveled all across the country, they've asked me something, and I want to explain it right now. They've asked me, what's different? It feels different. It smells different. I can't quite put my finger on it. I can tell you what it is, members. It's freedom. That's exactly what it is. For all of us here, we know hanging out in the free state of Florida, we enjoy it every day. So the weather's a bonus too, but ladies and gentlemen, welcome to the free state of Florida.
Thank you, Mr. Bean. I now introduce our witnesses, Dr. Kaufman, and we're very excited about you mentioned been 20, 25 years here, and with the institution, you guys have done incredible work. So thank you personally. Christopher Davis, and we've got a chance to become friends, but we want to be better friends going forward. He's focused on longevity and prevention. Dr. Odds, he was the medical director of Manatee Surgical Alliance. Dr. Hu is the president and CEO of Moffitt Cancer Center. And Scott Darius is the executive director of Florida Voices for Health. Thank you for joining us today. Your written statements will be made part of the record, and each of you have 5 minutes to deliver your remarks. And Dr. Kaufman, we'll start with you.
Thank you, Chairman, ranking members, and distinguished members of the committee. I'd like to really thank you for this opportunity to testify today and to share the work of the Lake Erie College of Osteopathic Medicine and the osteopathic medical profession. I serve as Dean at Lake Erie College of Osteopathic Medicine in Bradenton and began my career as a physician assistant. Came back to LECOM in 2000, got my DO degree. I'm board certified in family medicine, and I've been with LECOM in medical education for 25 years. It's an honor to contribute to this important conversation about modern medical training and innovative care in the American people. At LECOM, our mission's clear. We're here to prepare the next generation of healthcare professionals through 4 pillars of excellence. That's excellence in education, clinical care, research, and community service, with the goal of improving health outcomes for all humanity. This mission is reflected daily in how we educate our students, care for our patients, and partner with the communities we train and serve in. LECOM was founded in response to a national need for physicians and a more responsive model to medical education. We've embraced the innovation as a practical necessity to meet workforce shortages through our colleges of medicine, School of Pharmacy, dentistry, podiatry, and health services administration. One of the most distinctive elements of LECOM's approach is its commitment to multiple adult learning pathways. Our problem-based learning pathway places students in small groups where they learn through clinical cases, mirroring how physicians diagnose and treat patients, promoting knowledge acquisition, communication, and critical thinking skills. LECOM's pioneered accelerated, cost-conscious medical education, helping to reduce student debt while maintaining a rigorous academic standard. In addition to maintaining one of the lowest tuitions for private nonprofit medical schools in the U.S., our primary care scholars pathway for students dedicated to primary care specialties, our accelerated physician assistant pathway, the only program of its kind in the U.S. for PAs who seek to become physicians, and the accelerated pharmacy pathway allow completion of medical school and pharmacy school in 3 instead of the traditional 4 years, cutting costs by 25% for our students. By lowering the financial barriers, we enable more students to pursue healthcare careers, especially in primary care. LECOM's educational philosophy is grounded in osteopathic medicine of treating the whole person, mind, body, and spirit, with an emphasis on preventative care. This holistic approach aligns closely with national priorities to maintain healthy lifestyles and nutrition, improve preventative care, and lessen the impact of chronic disease. Our programs emphasize primary care, community engagement, and service learning. And actually, in fact, we have LECOM, 60% of our medical students enter into the much-needed primary care specialties while practicing in rural and underserved areas. The United States faces a critical need for a larger, better prepared healthcare workforce. LECOM addresses these challenges both through scale and innovation. As the largest medical college in the nation, LECOM has expanded access to medical education while maintaining a strong focus on quality and outcomes. Through the tenets and following the tenets of osteopathic medicine, our admissions process go beyond just grades and performance on qualifying examinations. We look holistically at all aspects of the applicant. In fact, LECOM is one of only a handful of medical schools that has an alternative to the MCAT. The LECOM Academic Index score allows applicants to apply for and be admitted to the medical school without an MCAT. This approach has led us to exceptional board outcomes and to a 99.4 to 100% residency placement for the last 8 years. LECOM's impact extends beyond the classroom through its integrative academic health system by aligning education with service. LECOM creates a feedback loop in which training programs directly respond to the community health needs. The work of the institutions like LECOM highlight several opportunities for policymakers, support for innovation and medical education models that reduce the cost and expand access, focus on preventative health care, including nutrition, and rather than the reactive care that we often see, and investment in primary care in underserved communities. Public policy plays a critical role in enabling institutions to scale these innovations by aligning incentives with outcomes such as improved population health, reduced costs, and workforce expansion. We can build a healthcare system that better serves all Americans. In closing, we stand as an example of how innovative education, community engagement, and integrative care delivery can come together to improve lives. We're proud to contribute to the health of the communities here in Florida and across the nation, and look forward to continuing to work with policymakers to ensure that every American has access to high-quality, compassionate, and effective health care. Thank you very much.
And thank you, Dr. Davis. You're next, but I did want to mention we're very excited about what you're doing, longevity and prevention. You're a leader in this area, in this region, and we're very excited. I hear that from a lot of your patients, frankly. So you're up.
Well, Mr. Chairman, ranking member, and distinguished members of the committee, I'd like to thank you for this opportunity, first of all, to speak to all of you guys. I want to begin with a story. It's the story of a little African-American boy growing up in a small country town in Virginia with one stoplight. When he was just 7 years old, the little boy faced a life-threatening health crisis, and his appendix ruptured, and the complications nearly took his life. He was hospitalized for weeks with tubes coming from every orifice of his body. It was terrifying. But because of the two noble surgeons, Dr. Teague and Dr. Gaylord, he survived. And during that illness, lying in that hospital bed, that little boy made a decision that would shape the rest of his life. He decided that one day he would become a doctor so that he could care for others the way those doctors had cared for him. Obviously, that little boy was me. Fast forward 30 years. After 4 years of college, 4 years of medical school, 3 years of residency, 1 year of chief residency, 2 years of NIH fellowship, 2 years of cardiology fellowship, and a year of interventional cardiology fellowship. I had achieved that dream. I'd become an interventional cardiologist. I was in the cath lab opening blocked arteries, treating heart attacks, responding to cardiac arrest, saving lives in the most critical moments. But by every traditional standard, I'd made it. Mission accomplished, or I thought. Because after about a decade of practice, I began to notice something deeply troubling. Too many of the same patients were coming back through the revolving door of our healthcare system with the same chronic illnesses, the same preventable complications, and the same fear. That's when I had to confront the hard truth. I was not truly practicing healthcare. I was practicing disease management or sick care. I realized that our system is incredibly advanced when it comes to treating illnesses. After it happens, we have a remarkable technology. We perform extraordinary procedures. We can do things in medicine today that would have seemed miraculous just decades ago. And yet, despite all of that, Americans are getting sicker. Chronic disease is rising. Metabolic dysfunction is rising. Cardiovascular disease remains the leading cause of death. And perhaps the most concerning of all, we have unintentionally created a system where patients often feel powerless. They're told what they have, they're given prescriptions, but they're rarely given an understanding. They're rarely given a roadmap. They are rarely taught why their disease developed in the first place, and they're rarely empowered to take control of their own health. That realization changed everything for me. In 2018, I took a leap of faith. I had to start over. I founded Reveal Vitality and Longevity Institute because I believed there had to be a better way to deliver true health care. A simple but radical idea guided that decision. What if we stopped waiting for disease and started identifying risk before it became irreversible? What if we asked not just what was happening, but why it was happening? What if we taught patients how nutrition, sleep, movement, stress, toxin exposure, and other lifestyle factors directly influence the development of this chronic disease? Today, that is exactly how I practice. Instead of relying solely on traditional labs, we go deeper. We use personalized, precision-based approaches, including genetic testing, micronutrient analysis, cardiometabolic biomarkers, and environmental toxin testing. I pause. We look upstream, and we involve patients in the process. The results can be profound. I've seen patients reverse metabolic dysfunction. I've seen patients regain energy, clarity, and hope. But what has moved me most is this. I've watched people go from fear to understanding the ownership of their own health. This is what healthcare should look like. But there's a problem. This level of care is still out of reach of far too many Americans. The people who need prevention the most often have least access to it. Underserved communities are often hit the hardest by chronic disease, yet they are least likely to have access to the time, testing, education, and early intervention that could change the course of their lives. This is not just a healthcare problem. This is a moral problem. Healthcare should not be a system that profits most when people get sicker. It should be a system that invests in keeping people well. If we truly want to modernize healthcare in America, then we must be willing to change what we value. We must reward prevention, not just procedures. We must reimburse for identifying risk early, not just treating disease late. We must support physicians in educating patients, not just moving them through the system. And we must build a healthcare model that gives every American, regardless of their income or zip code, a real opportunity to live a healthier life. Because in the end, the goal is not simply to help people live longer, it's to help them live better. With more energy, with more clarity, with more independence, with more dignity. If we truly want to empower Americans to have a healthier life, then we must stop waiting for disease and start investing in health. The question is not whether we have the knowledge to change healthcare. The question is whether we have the courage to do it. Thank you.
Thank you, Doctor, for your passion and what you're doing. And I also know that there's a lot to be said about you really do everything you can for children, especially children that are disadvantaged. So God bless you. With that, Dr. Reckes, 5 minutes.
Chairman, ranking members, and members of the committee, thank you for the opportunity to speak. As a bariatric surgeon, I see the human cost of our current healthcare policy every day as I treat patients with obesity and metabolic disease, conditions that drive diabetes, heart disease, hypertension, and it represents the majority of the healthcare spending that we do in this country. Our system is built to take care of ill patients, treating complications well after they occur. We really need to pivot our healthcare system towards treating earlier evidence-based treatments that will prevent these conditions. By the time patients reach my operating room, they've already suffered years of preventable damage. Treating obesity requires a coordinated approach that integrates surgery, medications, and prevention, policies that support earlier screening, expand access to telehealth, and incentivize value-based care can help us intervene sooner and reduce long-term disease burden. We already have the tools that we need to improve healthcare by recognizing obesity as a chronic disease, by expanding access to effective treatments, and supporting prevention and innovation. We can empower patients to live healthier lives while strengthening the sustainability of our healthcare system. We're not lacking the effective treatments. We're failing to deliver them early on. Thank you again for the opportunity to share my perspective. I'm happy to answer any questions. I did want to touch on certain topics. So first off, treating obesity as a chronic disease. Obesity is a primary driver for type 2 diabetes, hypertension, and heart disease, yet outdated policies still treat it as a lifestyle issue rather than a biological disease. Congress needs to expand coverage for evidence-based treatments, including medical weight management and bariatric surgery, to address the root cause rather than just the downstream complications. We need to expand access to proven bariatric treatments. Bariatric surgery is one of the most effective and durable treatments for severe obesity, yet access remains limited by insurance restrictions and referral barriers. Expanding access would improve outcomes and reduce long-term costs. Newer medications like GLP-1s based therapies such as semaglutide, tirzepatide have expanded our ability to treat obesity and show real promise. These therapies can produce meaningful weight loss, often in the range of 15 to 20%, and should be part of our comprehensive treatment strategy. They're important clinical advances, but they're only part of the solution. Surgery remains the most effective and durable option for severe obesity, typically producing 25 to 35% more weight loss, roughly double that of medications, and achieving higher rates of diabetes remission. These results are sustained over many years, while medications requiring ongoing use to maintain their effect. Surgery provides sustained metabolic improvement. As access expands, these medications should be used thoughtfully, prescribed by appropriately trained clinicians, and integrated into long-term care focused on improving overall health, not just short-term weight loss. Despite having these effective treatments, patients and providers face significant barriers to care. Administrative requirements frequently prevent timely, appropriate treatment. In many cases, the delay is not due to clinical uncertainty, but to administrative friction. We need to incentivize preventative care over sick care. We continue to reimburse treatments of disease more than prevention. Expanding coverage for nutrition counseling, metabolic screening, and medical nutritional therapy, including Medicare access to dietitians beyond simple diabetes control and chronic kidney disease, would allow earlier intervention and reduce long-term costs. Encourage earlier screening for metabolic disease. Many patients develop complications long before receiving treatment. Medicare currently covers nutritional therapy and related services primarily for conditions like diabetes and kidney disease after the disease has progressed. Expanding screening to coverage such as obesity, prediabetes, metabolic disease, and fatty liver disease would improve our patients' health. This would allow earlier intervention in at-risk patients before they reach a point of crisis. They're often the earliest signs of metabolic disease, yet they remain undiagnosed and undertreated. Aligning coverage with early disease, not just advanced complications, would improve outcomes and reduce long-term costs. In addition, expanding community-based preventative programs, continuing telehealth medicine to help patients that don't have access, and aligning payment models with outcomes improve public education, and reducing stigma. If we want to improve health care and control long-term costs, we must treat obesity as a chronic disease, expand access to effective treatments, and intervene earlier. We must apply the same clinical rigor to obesity that we apply to diseases like cancer and heart disease. We have the treatments, but access, not science, is now the limiting factor. Thank you.
Thank you, Dr. Wu. I want to just say we're excited to have you here. Moffitt's a clear leader, not just here, but across the country. And thank you for your leadership as the CEO.
Thank you, Chairman Buchanan, for all of your support through the years of our mission at Moffitt Cancer Center. I am Patrick Hu, the CEO of Moffitt Cancer Center, where our goal is and our mission is to prevent and cure cancer. We are located in Tampa, Florida, just a short drive away in this beautiful state of Florida. My background, I study the immune system against cancer. I first started at the National Cancer Institute, then at MD Anderson. In the last 5.5 years I've been here. We have amazing system in our body called the immune system that's able to locate, recognize, and kill cancer cells. And so that's what I've studied, the ability to stimulate our own immune system to recognize and kill cancer cells. And these immune cells can live in the body for decades, giving patients what they want. We've learned to take immune cells out of the body, put genes in them, give them back, kill the cancer, and give patients what they want, which is long-term durable response. So they can see their grandkids grow up, they can walk their daughters down the aisle. We've seen countless patients that have been cured from immunotherapy. The emphasis of today's panel on prevention and screening we love, because if you look at all of the kinds of treatments, prevention is the way, the most cost-effective way, and the best outcomes that we'll have. In Moffitt Cancer Center, we've always had in our mission statement, it's our 40th year now, from day one, we had our mission to contribute to the prevention and cure of cancer. We didn't just say cure of cancer, we've always focused on prevention. 40% of cancers are preventable. There's a lot of cancer. It's 50,000 deaths in Florida, 600,000 in America, 10 million globally every year die of cancer, and 40% are preventable. So a lot of people talked about obesity. That's really important to address. Cigarette smoking, we still have millions of Americans who smoke cigarettes. And cigarette smoking not only causes not just lung cancer, bladder cancer, kidney cancer, pancreatic cancer, many cancers, but also heart disease. So contributes to a lot of the morbidity and mortality in this country every year. So we have to try to prevent cigarette smoking. And of course, sunburns. I'm a melanoma doctor, so stay out in the fun sun. I love the hat, but don't get too much sun. So that's and then we call secondary prevention screening. Everyone's heard of mammograms for breast screening. You should start those if you have average risk at 40 years old. Colon screening, you should start at 45 years unless you have family history. You can start earlier. But one that a lot of people have not heard of is lung cancer screening. If you are a smoker and you get a 20-second CAT scan every year, we can catch the lung cancers early. We could save 60,000 lives a year in this country alone if we could do lung cancer screening. Right now, there are millions of smokers in America, and only less than 5% are getting these lung cancer screens. So please spread the word about the importance of lung cancer screening. We would have much better outcomes, much less therapy, and we would save the country just billions of dollars. A final thing I want to talk about is our research at Moffitt Cancer Center on nutrition and exercise. It's the most common question my patients ask me. Hey, what should we need better research because a lot of the research that's been done is, hey, how many helpings of fish have you had in the last 3 months? Well, who remembers how many helpings of fish they had in the last 3 months? So it's very inaccurate research. And so we have a food kitchen. I'd love for you guys to come up and visit us at Moffitt Cancer Center, see our food kitchen.
You got something in about an hour? Food kitchen. You said food kitchen. Come up and see you.
Yeah, come up. Come up. Please see us, and we will make you a nice breakfast, low carb, and we need to study that prospectively to get accurate research on how food. We're studying how food stimulates the immune system. If you have certain diets, we think some fasting diets, maybe the keto diet, which I've been on for 13 years, we think that might stimulate the body's immune system. So please come visit us to look at our nutrition research. And finally, Chairman Smith mentioned rural areas. I want to let you know at Moffitt, we're digitizing all of our pathology. The most important thing for a good outcome in cancer is knowing what kind of cancer it is. And so we're hoping that after we digitize our pathology, rural hospitals from across Florida and across America can send us their toughest cases, and we'll help them define what kind of cancer that is so that we can try to get the patients on the right treatment pathways. So thank you. It's been an honor to be here today.
And thank you, Mr. Darris. You're recognized.
Good morning, Chairman Buchanan, Ranking Member Horsford, and distinguished members of the subcommittee. Thank you for the invitation to testify today. I appreciate the opportunity to share our perspective on the healthcare system, but also to test the integrity of my wedding suit. Florida Voices for Health, we're a statewide health advocacy organization committed to improving access to healthcare for all Floridians. And we're very fortunate to be part of a statewide coalition of organizations committed to that work. As Voices, our work is really bringing the lived experiences of Floridians into the policymaking process. We try to empower people to share their stories for themselves and hopefully bring them to places where they can make a difference. So this setting right here is a great example of that. Our storytelling, it's taken us to the Panhandle where my now friend Debbie struggles to access resources for her disabled kid. It's taken us to South Florida where my friend Tasha has to take less hours at work so she doesn't lose access to her Medicaid coverage. And there are success stories too. Just yesterday, we were visiting a free clinic down in Winter Haven, where they have an innovative model where they're connecting people to transportation and food access and all the other things that we need to stay healthy. So as you explore ways to improve the healthcare system, I just only want to offer a couple of things that we've learned from talking to people directly on the ground. The first is that everyone's impacted by what's going on. All of us are paying a little bit more right now. And in Florida, where we had 4.7 million people enrolled in the ACA last year, the average monthly premium jumped up 30%. Now, for middle-class workers, for people who are earning just over 400%, they both had to suffer through the increase in premiums, but also lost access to enhanced premium tax credits, all tax credits. And so they're shouldering that burden all alone. For low-income workers in non-expansion states like Florida, there's actually a disincentive to work more. The most a single parent can earn in Florida, the most a single parent with 2 kids can earn and still qualify for Medicaid is $8,000 for the year. Anyone who finds themselves making more than that, $1 more than that, and you find yourself in what we call the coverage gap. I appreciate the focus on rural Floridians, which is where we've spent on rural people, and rural Florida is where we spent a lot of time focused the last 2-3 years. We've had 3 rural hospitals closed here in Florida since March of 2020. When it comes to oral health, which we know is so important to the rest of our bodies, we have 6 million Floridians living in what we call dental provider shortage areas, meaning there aren't enough dentists to see them. And that's to say nothing about Florida's mental health needs, prescription drug affordability, or, supports and services for people with disabilities. The point is, no matter how you slice it, income, geography, race, or the specific area of healthcare, none of us goes completely unscathed. The scope of these systemic challenges, I think, speaks to a second truth, which is that healthcare won't be fixed with a single policy. Our system's too big, and there are too many barriers that need to be addressed. I appreciate the comments on modernization and innovation that this distinguished group has offered today. I'm not a doctor. I'll make that clear. But it's amazing to see what we're capable of and why the U.S. is second to none when it comes to the provision of healthcare. But our system, I'll say, feels a little bit like a business that has the best product on the market, unchallenged. But we have one fatal flaw, and that's that we can't get it to people when they need it. To realize the full potential of all the models that exist here, of modernization and innovation, the fundamentals of our underlying system have to be strong. The new tools and treatments won't mean much if the people who need them can't access them. Now, I know that that's easy for me to say, and creating comprehensive policy takes a lot of people working together and working through tough questions together. So I'll offer just, a couple of guideposts as we work on building the system together. The first is that everyone needs to be covered, and that's just insurance math, right? We learned this as in this last year, insurers justified their premium increases. They pointed to the fact that they expected healthier people to drop off of coverage, and that made it more expensive for everyone else. The second is that we need to restore trust throughout the system. The entire healthcare system is based on a series of relationships that require trust for things to work well. And that's between doctors and patients, insurance companies and their insured, between the government and its people. And while, trust sounds like a high-minded ideal, I'll say that it actually has concrete policy implications. Our current system of prior authorizations and step therapy protocols reflect a distrust in providers' decisions. The lack of transparency in pricing makes it hard for anyone to feel like they're being treated fairly. And in programs like Medicaid, punitive work reporting requirements reflect a lack of trust in the American people. And by and large, I'll tell you, the people want to work. People want to meaningfully contribute. And lastly, a strong healthcare system adapts to each community's unique needs, whether it's to meet the distinct challenges of rural communities that are just 20 minutes apart, or to figure out why the maternal mortality rate for black mothers in Florida is 51.8 per 100,000, while the overall rate in Florida is closer to 24. The solutions need to be tailored. So, in closing, true progress will require not just innovation, but a recommitment to the fundamentals of ensuring coverage for all, rebuilding trust, and recognizing the unique needs of every community. Thank you.
Thank you for your testimony. We'll now proceed with questions and answer session. I'll begin by recognizing myself. I want to start by thanking our witnesses for sharing their time and expertise with this committee. I want to thank LECOM. Let's give them a round of applause for setting this up for us today. For hosting this wonderful event. I'm so proud to be able to highlight work that's being done in this region, in this area, for a lot of our patients and doctors and everybody else. Let me just ask couple of quick questions by show of hands. Please raise your hand if you believe nutrition, eating real food, and that's the key, what that means, but ideally eating real food is a key component to preventing and reducing chronic diseases. Second, keep your hands raised if you believe we could do a better job educating physicians and patients about the importance of nutrition. And finally, keep your hands raised if you think insurance, Medicare, and other programs sufficiently cover prevention and detection tools today. Well, that tells the story right there. I want to run through Dr. Davis. I want to give you an opportunity, because you've worked with patients and a lot of different patients in this region in terms of a lot of the things that you're putting in place. In terms of the longevity component, prevention we've talked about, how do you explain what that means, and how does that play out with your practice?
Oh, thanks for the question. I think one of the points that I want to make in that 5 minutes that we had, it was tough to try to decide what to put in 5 minutes. But let me, in my opinion, what I've been working on for the last 4 or 5 years, and I kind of stumbled into this. I wasn't looking for this, but at the end of the day, chronic illness, longevity, I would say that 90+% of all chronic disease is caused by toxins that we're exposed to in our environment. There's a lot of talk about this, okay, but we don't really have to talk about it. I can't see behind me, but by show of hands, I would like to know how many people have even had an environmental toxin test, metals, plastics, insecticides, pesticides, things like that. And I can tell probably behind me, and I can't see, not many, right? And at the end of the day, when you do testing like that, when I do it on every single patient that comes through my door right now, okay, it makes the conversation very easy, because those toxins, those pesticides, that glyphosate, that atrazine, the metals, the mercury, those are the things that we see that cause oxidative stress that actually contribute to chronic illness, and it diminishes our longevity. And what about longevity? Longevity is not living longer. It's thriving. It's taking care of your grandkids. It's being active and being able to do the things that you were doing when you were 30 years old. But what causes the problems there? It's inflammation, oxidative stress. That's all driven by things that we're exposed to. And in my practice right now, it is crystal clear. I don't think I don't have any more, it's crystal clear. And I look forward to the day when I could actually share all of that data. Share the data on what we really see, and each and every one of us, including myself, what we see that's in our system that's causing these diseases. So we have to wake up. We have to wake up, and we have to start looking at where the true causes are.
Yeah. Dr. Kaufman, you talked about nutritional training for physicians. What does that mean today here at the hospital? I mean, at your facility, I should say, LECOM. When you say that.
Thank you. We have a very unique curriculum here at LECOM Bradenton and our other campuses also. And part of that's problem-based learning. And problem-based learning is case-based education from day one. So when the students come in and they're learning about a 54-year-old with chest pain, it's more than just the symptom and the diagnosis. It's a delving into a lifestyle and the nutritional component that goes with it. So we do have nutrition in our programs, and we have, with each case, the nutritional components that go along with it. We have committed to expanding our curriculum already. We're very proud of what we have, but we're going to expand it even further. And it's really a refocusing on prevention instead of reactive medicine. It's much more expensive to treat the heart attack. It's much more expensive in the terms of their quality of life after they've had a heart attack than it is to prevent it in the first place. So that's really the focus and how we give it to our students so that they understand that each disease process is not only treatable, but preventable.
Yeah, let me add on to that a little bit. I believe screening is a critical component of preventing diseases. In the House, I lead bills to increase screening on lung cancer. It's unbelievable that's the biggest killer in cancer, what I've been told, but yet we're not doing much, not enough in screening in that area. For lung cancer and Alzheimer's disease, I know we have advocates in the attendance today supporting these bills, and I want to thank them for all their support over the years. Dr. Wu, let me you talked about prevention and screening, and and I've heard you said 50% get screened early, but I've also heard the number that 95%, if they catch it early, the cancers, there's a good high probability you can take advantage of that, live a normal life for a long time. What's your sense on terms of screening? Because it seems to me, I tell everybody, get a physical once a year in January, minimally, and maybe some tweaks and adjustments, you catch it early. My mom, unfortunately, had colon cancer. By the time we went in, it was so advanced, you couldn't do much with it. But the idea of prevention, especially one of my bills is on lung prevention, trying to catch that early. And I lost my assistant to lung cancer and her husband, same thing. And so I've been around a lot of that. As you get older, you see a lot of that. But it just sure seems like we've got to do a better job of educating, getting people out there to take, make sure they're doing all the right things.
Well, thank you for that question, Mr. Chairman. You are absolutely correct. If we can screen and catch cancer early, we can cure the cancer. So I treat melanoma. Melanoma starts in the skin from sunburns, and it can go to almost any organ in the body. But if we catch it early and cut it out, it's almost always cured at an early stage. And so the key is to catch these cancers early. And thank you for all your support of lung cancer screening. One thing that would make it really much easier, I know you're supporting on this, is if we can get rid of the pre-authorization for lung cancer screening. It just makes so much economic sense for the country. And Congress did a great job helping us with mammography so that there's no pre-authorization on mammography. But if we can get rid of the pre-authorization for lung cancer screening, it would be a lot easier to go. We have a van with a CAT scan in it, and we go to church parking lots all over Florida trying to find smokers to get that 20-second screen. But we have to make sure they're pre-authorized, which means we have to come back to the church parking lot the next week, and we can't just spontaneously pull up. And so that would be of help. But thank you for your emphasis and your support of prevention and screening.
Yeah, thank you. And now I recognize the gentleman from Nevada, Mr. Horsford, for 5 minutes.
Thank you, Mr. Chairman. Thank all of you for your testimony today and for being here. And I agree, our healthcare system is at an inflection point. The status quo is not working, and we need fundamental change. The question is, what does that change look like, and where should we start first? We do have one of the most advanced healthcare systems in the world. The problem is it's leaving far too many people out, and it's not working, especially for those without the resources or the connections to navigate it effectively. Mr. Darius, over the past year in a lot of the constituent town halls that I convene, my constituents tell me all the time that they don't want to go back to the status quo. The status quo doesn't work for them either. So in your testimony, you note that while modernization and innovation are worthy goals, and they are, to fully realize their impact, the fundamentals of the underlying system must be strong. So can you talk to us about what those fundamentals should include? What is that foundation that we should be working to make sure is in place for everyone?
Yeah, and I think, thank you for the question. I think the exact answer, right, is the work that we can all do together to work through exactly what that looks like. But generally speaking, I think it's a system where everyone is covered, just because that's the way insurance works. So whether it's through a patchwork of the programs that we have currently and finding ways to make those work more efficiently, or if it's through a different system, right, where everyone's covered in a more streamlined way, I think that's worth pursuing. I think finding ways, again, I'll say, to build trust between all the entities that are in the system itself. How do we kind of recognize the expertise that different people have, right, whether it's providers or insurers, whatever it is. How do we recognize that level of expertise that exists in the system, and also to just trusting average people? I think so much of the policies that we talk about just have a hint of distrust of working people. I'll say that. Again, I talked about this coverage gap that exists, right, where you have people who, if they earn $9,000, they're suddenly too rich for Medicaid in Florida, but also don't qualify for tax credits in the marketplace. So all over throughout the system, there are these kind of conflicting incentives, right, or just gaps that exist. And I think if we sit down together and work through, what the ultimate solution looks like, that's possible, but just fundamentally keeping some of those kind of guideposts in mind as we build that out.
Yeah. I also appreciated the comments about clearly there needs to be more attention on the metabolic disease crisis, and that obesity is a biological disease, not a personal failing. Diabetes, kidney disease are all downstream consequences of metabolic dysfunction, and I think that is something that we need to tackle further. Dr. Davis, your testimony, I could feel it in your heart, the passion that comes through, and the fact that you went into this profession thinking you were going to change it in one way, and while in it, you realized there was another approach that needed to be taken. And I fundamentally agree. We need a wellness-based approach, not a sick-based approach. So can you talk a little about, again, the determinants of health, nutrition, stress, environmental toxin remediation, as you stated in your testimony, which are root causes of disease throughout our country, and where those elements should be. Because unfortunately, they're not a high enough priority when we're cutting research or cutting funding or cutting access to food, not providing access to stress or wellness mitigation and other environmental issues. Can you speak a little bit more to that, please?
Absolutely. Again, thanks for that question. I think I'll start by just kind of talking about how I made this transition from an interventional cardiologist, doing the things that I was doing 10 years ago, to the type of medicine that I practice now. And it started with just really a program where we focused on 5 basic pillars. We focused on nutrition and movement and detoxification, sleep, and stress management. And what I was doing, I had one day of a clinic where I just would help. We had a wellness program, right? We developed a wellness program that was a 6-month program. And we basically taught people about all of those different pillars of health. And very shortly, 2-3 months into doing that kind of wellness program, what we did monthly was we had the patients who had enrolled for the program. We'd come into my office, we'd sit around in the front in the waiting room, and we started off by saying, everybody, let's go around the room, let's tell your win for the month, right? And it was absolutely amazing to me as we started this program how, everybody would stand up and they would give their kind of what happened. And, things like headaches going away, their rashes going away, I lost 20 pounds, I no longer have the arthritis issues. And I remember distinctly, we had a room set up with a table up in front where we had different presentations, and I used to sit in the back corner of my office. Now I sat way back in the back. And I remember thinking to myself, 2-3 months in, I was like, man, I got this all wrong. Got to figure out how we do this. Like, how do we fix this? And so in just addressing those pillars of health and teaching them, it's about education. It's about the things that they don't know, the things that I didn't know as a physician, right? All the stuff that, how many years did I tell people you need to eat a low-fat diet and go get some exercise and then hope they come back and they're better, right? What did I truly do to get them better in that visit of 7 minutes and saying, yeah, you really need to lose some weight, and with no instruction, no roadmap? And so when we started to do that and we started to give them the roadmap and addressing those pillars, things started to change. And so really that is what I think we need. We need education. Physicians need education. Patients need education to empower themselves to take control of their health. Right now they have no clue. So that's kind of, I think, what we need to be focused on. How do we roll out wellness programs to empower people to take back their own health, right? To motivate people.
Your comment said to move from fear to ownership, from prevention to access, to change what we value, and to reward prevention, not procedures. I think all of those are qualities that Chairman Buchanan and other members of this committee are working towards. It's why he wanted us to be here to hear from all of you. So thank you again for your testimony today.
I now recognize Chairman Smith for any questions he might have.
Thank you. I want to thank you again, Chairman Buchanan, for pushing this topic during your time in Congress and for inviting us to your congressional district. I was reminded, listening to your testimony, of a healthcare roundtable that I had when I first became chairman 3 years ago in Nashville, Tennessee. And there was an individual there that was like, Chairman, just remember that healthcare will follow the dollar. And Mr. Davis, your comment, your statement, I wrote it down. I thought it was so spot on. Should not be a system that profits when people get sicker. And so if you have the leader of some of the biggest healthcare entities saying that, remember, healthcare will follow the dollar, but if we don't use the dollar to provide preventative care, but instead provide it whenever you're very sick, where are they going to place their money? And so I think this discussion is absolutely wonderful for us to be having so that we actually get to fixing the broken healthcare system, because it is absolutely broken. And if anyone tells you otherwise, then they've never participated in any kind of healthcare. A big part of modernizing our healthcare system begins not in the halls of Congress, but in the classroom and practical medical residencies, equipping future physicians, nurses, and other medical personnel with a foundation that prioritizes not just treatment, but prevention and access to quality care that is close to home. Dr. Kaufman, thank you once again for hosting us right here at this beautiful school and for this informative discussion. But 64% of colleges of osteopathic medicine require clinical rotations in rural and underserved areas. Doctors who train in rural areas are 5 times as likely to stay and practice in a rural community, helping those Americans get needed access to care. What more can we do to encourage this training and rural access to care, to ensure the next generation of physicians is equipped to treat the chronic diseases that disproportionately affect rural Americans.
Thank you, Mr. Chairman. So part of that begins with GME and a priority on rural or underserved. You hit something right on the nose with the type of students who become physicians who practice in rural areas. So it begins with who we're accepting in medical schools. As I said earlier, it's more than just a GPA or an MCAT. We're looking for first-generation students, like myself, who had a mother that was worked at a car dealership and a father who was a military careerman and electrician. So these are the people that understand the value of a medical education. They're dedicated to it. They have resiliency. So if we look at just the standards of an MCAT and a GPA to get them into medical school, that's not a whole person approach. It's not an osteopathic approach of mind, body, and spirit. So starting with the student level, if we provide them rotations in the rural area, like you mentioned, what happens if they're exposed to that area is then they search out residencies in that area. And that Florida's done a fantastic job in expanding their residencies in the last 10 years. I think it was 25% or 27% from 2016 to 2021, another 27% the next year or next 5 years. So an amazing job. More of my students are able to stay in Florida because of the residency opportunities, but there's room to grow. So if they do their rotations in a rural underserved area or a health manpower shortage area or a needs area, and they choose to do their residencies there, then they stay in those areas to treat the communities that help train them. So my patient or my student load has changed from their geographical areas where they come from. In the past, I had about 60% of my students came from Florida. That's reduced, but the good news is they stay here. And the residency opportunities that they have, may not have been from Florida, but they're staying in Florida, including the rural underserved areas, to treat those communities that they trained in.
That's great. We have witnesses here today that are putting into practice treatments and methods of care that help prevent chronic diseases that are the cause of so much patient suffering and billions of healthcare dollars spent, as we discussed. But we must bring the financing side of the equation on board with a more modern system when it comes to reimbursements. Dr. Davis, can you share how you are practicing what you're preaching and encouraging prevention, not just as a physician, but as an employer with your own team, and what are the challenges and opportunities you see that would facilitate more widespread investment in preventive medicine?
All right. Thanks again for that question. This is a very, very important question with respect to reimbursement. What's been prioritized from a reimbursement perspective? I like to tell the story of years ago when I was practicing interventional cardiology. I remember making flyers to do peripheral vascular procedures because they paid $15,000, $20,000 a procedure. And the reality of the matter is, it wasn't that we were doing anything wrong, but the truth of the matter is we do the procedure and 6 months later they come back and it's another $10,000 to $15,000, and 6 months later they come back, it's another $10,000 to $15,000. Because we never looked at the underlying root causes of those disease processes. And a lot of the times, the patient really didn't have any significant outcome benefit, but there was a blockage in an artery, so we put a stent in it or did an atherectomy to fix it. I think about those days now and think about where that money could be spent with the things that we're doing with an education perspective and all of the other things that we're doing in my practice right now with the right testing. Insurance doesn't cover an environmental toxin test. The insurance doesn't cover that micronutrient test that we're doing, the genetic testing that I use on every single patient. If I had the money that we got paid to do those procedures to utilize on every individual, I could guarantee you that their health would be improved tremendously, and the health of the nation would be improved tremendously if we had a refocus on where those dollars are spent. So, and I think that that's just a cardiologist's opinion. I am sure there are things within the whole system that are the same way. Like what we are paying for and what we're not paying for, the values are all wrong. So that's where I think we need to start focusing, like looking at really what are we paying for, what are the outcomes, and what really moves the dial, where are we getting results? come look at my 82-year-old who has severe coronary disease that everybody wrote off, that said he could go home and die, whose heart function is getting better and better and better with the things that we're doing now, right? So that is what we need to focus on. We need to focus the dollars on the things that really make a difference.
New state-of-the-art procedures are helping treat and making a real difference for Americans with chronic diseases, including innovative treatments and surgeries for those struggling with obesity. I'm hopeful that in the future, digitally assisted and robotic surgery has the potential to bridge geographic disparities in care, access, and make procedures safer and more predictable. That starts with educating and training physicians to take on this innovative technology. Dr. Reckes, I appreciate you being here, particularly given that much of what we are focused on today is to keep as many as patients out of your operating room as possible. Tell us about your experience with robotic surgery and what prompted you to undergo training to perform surgeries using robotic technology. Additionally, where do you see this technology going in the future to eliminate access disparities and encourage innovative technology in more rural areas?
So, thank you for the question. I mean, it is a truly amazing time that we live in. There's so much technology and access to things that we have. Robotic surgery has been an amazing tool for me as a surgeon. I love the idea of pairing current technology with helping patients. What got me interested in robotic surgery was the outcomes. We're doing surgeries on patients for colon cancer, for example, that used to stay in the hospital for 7 to 10 days that are now going home in 1 to 2 days. I never thought that'd be possible. We're actually doing bariatric surgeries faster, and I never thought that would be possible because of the robotic technology. So it's allowing surgeons to operate better, see clearer, and especially for our larger patients, instead of me carrying the weight, standing over a patient, I'm sitting at a console and I'm controlling, and this robot is expanding what I can do for them. As far as where it's headed, the potential is really limitless. You know, we're not there yet, but eventually this technology was first kind of created to be able to take care of patients miles away, and maybe even in different states and different countries. So all that potential is there. But the tool, the robot, doesn't matter as much as the outcomes. And I think for me, we get people to go into these different specialties and provide the best care by incentivizing them with their outcomes. Paying more for providers that decrease length of stay, get patients back home to their families, have less complications, and spend less money in the hospital. Currently, we're still rewarding these complex cases that are requiring the most amount of money. So if we fix the focus on incentivizing people to do better care, keeping people out of the hospital, and as far as your question goes about keeping people out of my OR, I agree. I have more patients than I want. 10% of the country would probably benefit from bariatric surgery. There's more patients than I need. We need to prevent them, but from getting sick, but the technology is there. But until we incentivize patients and until we make it easier for providers to refer to dietitians and decrease the amount of money that patients are having to spend, patients are afraid to go to a hospital. They're afraid to go to a provider. They're afraid to go to a dietitian because of their copays. And the amount of time that my office spends dealing with appeals and trying to fight for the care that patients should be getting is one of the other biggest factors. So if we change the payment structure, I think the rest will follow.
Perfect. One quick question. Dr. Hu, you have been at the forefront of cancer research and innovative care delivery. Many patients seek care in line with their insurance coverage. How are you working with insurers to ensure that they offer modernized benefits and that they design coverage options that encourage prevention, innovative care, and encourage better recovery?
Thank you. That's a great question. We're trying to work with them to emphasize this importance of prevention and screening and how they can actually save a lot of money in the long run and get much better outcomes if they can focus on coverage of prevention and screening with as much streamlining as possible. If we have to go through a lot of pre-authorizations, it's really challenging sometimes, just adds a lot of labor and bureaucracy, but I think it's really a no-brainer in terms of the finances of what we would save. Healthcare in this country, as you guys recognize, is not sustainable. We have to do this. We have to focus on prevention and screening. It's our only way out, and it's our way for the healthiest of America.
Thank you. Thank you, Chairman.
And thank you, Congressman Stubbe, you're recognized.
Thank you, Mr. Chairman, and thank you, Chairman Buchanan and Chairman Smith, for allowing us to have this field hearing in beautiful Southwest Florida. I'm glad that some of my colleagues can experience the incredible Suncoast hospitality in the free state of Florida as business leaders and innovators continue each day to make this the best state in the country to live, work, and play. Southwest Florida is home to world-class providers, innovative surgeons, and one of the nation's premier cancer centers, Moffitt, and a major osteopathic medical school pipeline. Yet our seniors and families still face a system that too often pays for sickness instead of wellness. I hope this hearing will allow us to focus on how we realign incentives towards prevention, early intervention, and better outcomes. Southwest Florida has retirees, seasonal residents, working families, and rapidly growing suburban communities all using the same provider networks. What unique care coordination challenges do fast-growth regions like ours face, and how can federal policy avoid a one-size-fits-all solution designed for urban academic systems? I open that up to anybody.
I think one way to solve access is through digital access. And so it is challenging sometimes for us to even do telemedicine across state lines or throughout a large region. And so the easier that is unified, I think it's the better. In these rural areas, the importance is not just to have enough doctors there, but to give them the support that they need. And that includes things like digital pathology so we can help them diagnose, but also the expertise of specialists. And that only happens through, that can happen through digital support. And I think the more we can enhance that ability through the system to have digital support across the state and the country, the better for the patients.
Conservatives believe that patients should be empowered to take charge of their own health, not trapped in a system that only pays once disease has advanced. How can we design better reward for individuals who engage in preventative screenings, nutrition programs, exercise, and chronic disease compliance? Dr. Rikas.
It's true. I think we really need to focus on prevention, and I do think we need to make sure patients take care and take part in their own health care, but we have to incentivize them. So why can't we do things like decreasing copays, doing things like rewarding them for taking part in preventative health care? We have a system now that will pay for diabetic medications, they'll pay for high blood pressure medications, but I have to fight for my patients to get a referral for a dietitian to teach them what a calorie is, what a protein is. So we have to push the responsibility on the patient to some degree, but also reward them by helping them make good choices, and by doing so, it's going to help the problem overall. So the biggest thing is really patients are afraid to come in early because they're terrified a lot of times of the cost. And even providers are, again, de-incentivized for sometimes referring patients for extra help because of capitalization and how the healthcare dollars are being spent. So fixing that is going to help our patients do the correct thing.
You'd like to add on that? Go
Yeah,
ahead.
if I can jump in just to say that I believe, I forget who said it earlier, but the outcome itself is an incentive for people. Folks want to be healthy. It's the fear, just to piggyback on this, the fear of the outcome, right? That you go into a preventative screening and you get this diagnosis, and now it's a thing that you have to treat ongoing. And I think for low-income folks, for working-class people, middle-class people who don't have comprehensive coverage, it's the fear that there's going to be more and more costs from that one thing. And so, you know, ignorance is bliss sometimes.
Dr. Hu, Moffitt's one of the crown jewels of cancer innovation in our state. What barriers still prevent earlier screenings and faster diagnosis for Medicare-age patients in Southwest Florida, particularly in suburban and rural communities? You had mentioned the prior authorization for the lung screening, but is there other things?
I think it's education. A lot of people have not even heard of lung cancer screening, and a lot of smokers, we have 1 million smokers in the state of Florida, and only 3% are getting lung cancer screening. The other 97% probably haven't even heard of it, and their doctors may have not even heard of it. So the more we can educate physicians and patients about screening opportunities, the better.
Is the problem access to care, workforce shortages, patient education, or outdated payment systems?
I think it's all of those things, and education is number one. They have to know about it, but then it's hard to access, and a lot of the people that need it have 2 jobs. They can't go take the buses to get their screening done, or have someone there to help them get to the screening, and then the reimbursement's an issue. But lung cancer screening is almost always reimbursed by many systems, and I think it's mostly the education of the patients and the physicians.
Thank you all for being here. I yield back.
Thank you, Mr. Bean. Congressman Bean, you recognize.
Thank you very much, Mr. Chairman. Once again, good morning to you and good morning to everybody. I'm going to tell you something that you might find hard to believe. I know we're all getting along up here right now, but sometimes Congress goes at it. We debate each other, and we go hard. And one of the best debaters, and he's on the other side of the aisle, is my friend from Nevada. Don't let his mild-manneredness fool you. He is a fighter, and we're on the other side. But he said something. This is going to shock everybody. He said something that I'm totally on board with. Our current system, healthcare, is broken. Unsustainable, broken. We've got to find a way to change it. It's broken on one hand. We're just a sick country. We are sick, and you compare us. If you look at United States versus other countries, we're mediocre health, and in many instances, we're behind the times. And you look at pictures of Americans at the beach, we're all heavy. And you look at pictures of Europeans, they're all skinny. I don't know what that is. And then you look at the numbers. It's not just weight, but it's also chronic diseases. Americans, hey, we're number one in chronic diseases. 42% of Americans have 2, not just 1, 2 chronic diseases, and that eats up everything. So we're going to talk about how to have that change. So we're sick on one hand, but we're also, it's unsustainable. And I look at my friend here, who Mr. Smucker, who we share a passion of attacking the debt. It bothers us. We're on a mission to get it done. We can't afford it anymore. We're spending over 40% of every dollar that we're borrowing, most of it from, to fuel this mediocre system. I do know this. As sick as we are, I do know this. We've got world-class providers, because if you're sick somewhere else in the world and have money, then you come here for treatment. So we got to figure that out. How can we get out of the way of providers and let them do their thing? It starts with physicians, and we're here at LECOM. It's great. I've already talked to a couple of your first-year students who have you cut up the dead body yet? Yes, they have. So I know that's the first step of becoming a physician. In Jacksonville, you're opening up this fall in Jacksonville. I'm really excited about Jacksonville University becoming part of the LECOM family. Members, do you know this, how we divide up training and residency programs? Members, you may or may not. The federal government has a plan that they started in the 90s. And they've locked all these states in, and states that have exploded in population are still stuck behind in the 90s. Smaller states like Massachusetts and Connecticut and New York are getting more of the lion's share of residency. So I was in the state legislature. Florida puts up its own money in many instances to fund these residency programs. But Dr. Kaufman, what would it mean if we could have a reshuffling of residencies or have more residencies? Could we make more doctors in Florida? And are we facing a shortage?
Thank you, Congressman. Yes, absolutely, we're facing a shortage. There's a report came out 30 years ago that said we had too many physicians in the country, and we know that was wrong. So the expansion of GME, again, has to be prioritized on primary care. When you have the debt of medical school and you come out and you've had 21 years of education minimally, as you were explaining, my colleague, about you do 4 years of undergraduate, 4 years of graduate school, then you do 3 to 5 years of residency, then you do a fellowship. The debt expands more and more. And in those residency programs, it's incentivizing students to go into specialty medicine where we really need primary care.
And go after the money. Mr. Chairman, I know Missouri is like Florida. You're shortchanged because you've also been locked in. We've got the Bean plan that residencies should follow the census. Every 10 years, let's look at it. Because the answer, and this is going to Dr. Davis, and I know I want to give a shout out. You have a lot of advocates for Alzheimer's and other challenging diseases. I'm going to ask some of you, bring hope. What's our hope to Alzheimer's? Be thinking of that question. But how do we restructure? How do we restructure? I know we have to have a focus on prevention, but the question is, how do we do it without more money? We just can't say more money is the answer to everything. We have to restructure what we already have. Dr. Davis, what would you say to that? How do we have a front end, a realignment? Is there a magic formula, or I don't know?
Well, I think it's the answer to the last question really is what are our priorities? What do we value? And if we place the emphasis on educating the doctors about nutrition, about sleep, about all of the things that truly cause chronic disease, and we educate our patients about those things, then we don't have to spend more money. In fact, we would end up likely spending less money because we would have less heart disease. We've had less Alzheimer's disease. We'd have less cancer. There's a big elephant in the room that we haven't talked about here. This is not just a medical problem. This is a societal problem. And the reason we don't address all of the issues with the food sources that we have, the processed foods that have all those chemicals that I'm talking about, we have to address the upstream problem as well. We can keep talking about how we're going to treat patients and how we can divvy up the money and all that type of stuff. But if we don't start at the top where the problem is starting from, then we're just going to keep shuffling things around, right? So we can't avoid the elephant in the room of where the problems are coming from. Agricultural things, spraying all of the pesticides. Glyphosate is not even allowed in most countries.
I know it all adds
right?
up. And,
so,
just like you about trying to fit it all in 5 minutes, that's the story of a congressman's life. Every day we try to fit it in. So, Mr. Horsford, looking forward to working with you as we come up with a solution. Last thing, and I can't see the clock. You're a minute over. Okay. Is there anybody? There's so many Alzheimer's advocates sitting in the audience. Can anybody say anything to bring them hope? That's one of the most challenging diseases out there. Is anybody, Dr. Hu, I know you're on the cancer forefront. Anybody have any good news to bring the Alzheimer's advocates this morning?
Well, we just hired a dentist at Moffitt Cancer Center that studies the microbiome, the oral microbiome, the bacteria in the mouth and its influence. And research has shown that the bacteria in gingivitis is found in Alzheimer's plaques. So since I saw that data, I am flossing every day now. And so I think that is our weak point, the gums, because bleeding gums allow the bacteria in the mouth to get to the brain. And we found the same bacteria is in brain tumors. And so besides not getting sunburns, floss.
Sun is blocking the clock. I couldn't see it at all. So,
it's the same thing back home, too. It's the same thing. Anyway, Congressman Smith from Nebraska, you're recognized.
Thank you, Chairman Buchanan. Vern, if I might, it's been great serving with Vern and his leading of Team Buchanan and MVP for Team Buchanan, Sandy. Great to see you here today as well. We've gotten to serve together for some time now, and I'm grateful that we can be here in your constituency to hear from folks with some great insights. So thank you very much. We're hearing about access. I think every comment has reflected at least somewhat on access. And I'm trying to do my part on my bill to allow pharmacists to be reimbursed by Medicare for testing and treating mild treatment for COVID, flu, and strep to increase access, and I think can lead to better outcomes. I think of the various characterizations of what Congress, the government did some time ago that was called the Affordable Care Act, but if the name alone is an indicator, it's a miserable failure. It's a colossal failure, in fact, to even consider calling it the Affordable Care Act, when we know that even folks with some great health plans over the years, I think of the public school teachers who don't have the health care plan that they once did. not to mention other groups, that the pressures have been so great by mandates, prohibitions, requirements, this, that, and the other, but government-centric, that it has not delivered good outcomes, and not just cost, but the fact is America is no healthier for the ACA on the books than even before, and especially given the warnings that the individual market would see drastically increased premiums because of the government mandates. We're seeing those, and that's even with tax credits still in place that have been there for some time now and still remain. And so I think we just, there's so much work to be done. I can't even begin to think what we could talk about in these short periods of time. But if we could get more specific, Dr. Kaufman, you talked about GME and residencies and so forth, and that this is an issue that is heavy on my mind. I represent one of the most rural and actually remote constituencies in America, in rural Nebraska. I have 80 counties in my district, so I have a lot of constituents who live far apart, a lot of cattle in between probably, but the fact of the matter is access looks different there than, say, in a more urban area, and it's all important. America's a big country, and I fully realize that, but I think of GME and Match Day, for example, kind of in the season of Match Day, right about now, and that roughly 5% of the graduates won't match. And those are highly qualified students who not only got into medical school, but are about to graduate, and they're kind of in limbo. And I have to think we can do better on that front. And I was just wondering, GME, the biggest funder of GME is Medicare. Medicare is within our committee jurisdiction. What could we do better inside Medicare, even outside Medicare, to be more efficient, if you will, at pairing medical graduates with opportunities when we know there is such a vast shortage of providers that how can we do it better, perhaps?
Well, it goes back to the allocation of residencies, too. So we have to prioritize primary care. We have to prioritize the location of those residencies in the areas that they need to be. So osteopathic medicine has a background of developing in rural America. It's truly the only physician practice that is born right here in America, and that was rural. So that's been a focus on primary care from the very beginning. There are caps on residency, so what about the possibility of raising caps in these areas that are restricted because it is a rural area? You have to train the students there. Why don't we incentivize the physicians who take students on rotations as a tax break to allow them to slow down their practice a little bit to bring the student in and help train them? Because again, if they train there, they're going to go to residency there, and then they're going to stay in the communities that treat them.
Mm-hmm. Perfect. Thank you. Dr. Hu, if you might elaborate perhaps, with a very rural constituency, your mobile screenings, have you considered how to maybe mobilize out where folks live a little more distance from each other?
Absolutely. I think mobile screenings are going to be important. The other is to give support to these doctors, because the reason outcomes are great at Moffitt Cancer Center is we're highly specialized. But you can't afford to have those highly specialized systems in all the rural communities, but we can give support. So I already mentioned digital pathology, how a pathologist in a rural community could scan in a slide and send it into a center like Moffitt Cancer Center. The other is to give support to the doctors. I'm a medical oncologist. There's not enough medical oncologists in the future. So we're developing AI programs because it's so complicated. Every month there's new approvals, new ways to treat cancers. It's so complicated. We're developing an AI module to help go out into the rural communities to give them support.
Very good. I'm glad you mentioned the AI portion, because I think that's, I'm excited about the future for healthcare as it relates to artificial intelligence and mobile screenings through one's smartphone, probably. That's probably the ultimate in mobile screenings at this point, and for the future as well. So thanks again for your participation here, sharing your insights. I yield back.
Congressman Estes, you're recognized.
Well, thank you, Chairman Buchanan, and thank you for all of our witnesses for taking your time to be here today and helping to share your expertise with us on the committee. You know, when we look at our nation's financial commitments, it's clear that we've allocated a massive amount of our economic resources to medical services. Yet, despite all this tremendous financial output, the overall well-being of our citizens is not keeping pace. We're effectively funding a sick care system rather than a true health care system. Today, a significant majority of our population is struggling with ongoing long-term illnesses, which stand as the primary drivers of mortality in this country. The burden is especially pronounced amongst our seniors. Nearly every individual enrolled in Medicare is managing at least one of these ongoing conditions. Consequently, our federal safety net programs are pouring hundreds of billions of dollars each year into managing these ailments already after they've already developed. What is particularly frustrating is the vast majority of these long-term conditions and the tragic early loss of life they cause could be mitigated through proactive lifestyle adjustments. Yet our current framework currently discourages that. We dedicate an incredibly small fraction of our national health budget to proactive upstream services, and Medicare reimbursement structures consistently fail to reward primary care providers for keeping patients healthy. We're also failing at the education level, as most medical students graduate without some basic mandatory coursework in clinical nutrition. In our rural communities where specialized facilities are hours away, strong primary and preventive care isn't just an option, it may be the only option, and it's an absolute necessity. If we want to rein in costs and truly improve the lives of Americans we serve, we must realign our healthcare incentives. We need a system that rewards early detection, values the comprehensive care models championed by our osteopathic professionals, and gives patients the flexibility to invest in their own wellness. I'm proud to say that we have the Kansas College of Osteopathic Medicine right in my district, and they are working hard to train the next generation of physicians in exact comprehensive patients first models. It opened just 4 years ago, and already we're seeing some results out of that. I look forward to talking about how can we improve our system as we go forward. You know, Dr. Davis, you made a significant shift in your career, moving from a reactive intervention cardiologist to focus on longevity medicine and stopping heart disease before it developed. As you work to identify the root causes of these conditions, you've talked about it some earlier, but how do standard insurance and Medicare actually cover for some of the early detection screenings that you need for your patients? And what works and what doesn't work, and what specific policy adjustments should Congress consider to ensure that our financing models prioritize the kind of regular prevention over late-stage expensive surgeries?
Well, thanks. It's a great question as well. I think part of the issue is the testing that we do. I think, let's just use heart disease, for example. And we'll talk about cholesterol, and we'll talk about when we go to the doctor, we get our cholesterol checked, and the cholesterol is your total cholesterol, your LDL, your HDL, and your triglycerides. Well, we know that there are much more advanced tests these days that look at the type of cholesterol you have, the size of the cholesterol particle, so whether that cholesterol particle is oxidized or not. Those are the true type of cholesterol. That's the cholesterol that actually gets involved in the vessel wall and causes heart disease. But many times that testing is not covered by insurance. Now, things are getting better. There's a molecule called lipoprotein a, which is a direct independent cause of heart disease that for years, I've been measuring it for 10 years now, but for years it wasn't covered. But it is a major risk for heart disease. So it really starts with getting insurance companies to cover testing that truly is upstream and is going to show us where the true risks are. I mentioned before environmental toxin tests. I mean, unfortunately, the people who come to see me, I don't take insurance in my practice, but the people who come to see me, they get environmental toxin testing. I can show you the mercury. We can do preventative screenings all day, but the mercury that causes the heart disease, the mercury that causes the Alzheimer's, the mercury that causes the cancer, like we have to start way upstream. Screening is great, and we have to do screening. But true prevention starts at the root.
Excellent, thank you. Dr. Kaufman, we've talked a lot about the GME. Obviously, my district has a rural area as well as a lot of our members on here, and you've mentioned a lot talking about it. And I don't know, as we look at the Medicare-funded GME slots are really concentrated in those large urban areas, and you talked about it earlier a little bit about the allocation process for those slots. Is there anything else you want to add in that dynamic of what we should focus on?
I apologize if I said it already. But, I have so many thoughts running through my head as I hear all this discussion. But one of the things is the incentivizing of the students to go into primary care residencies, and we're talking about family medicine, internal medicine, pediatrics, and family medicine, obviously. So if we did loan forgiveness on that debt to drive them into those areas, that would certainly help them to spread out across the country further than they are at this point.
Excellent. Thank you. And thank you all for being here. I'll yield back, Chairman.
Recognized.
Thank you, Chairman. Thanks for holding this hearing. This is a wonderful panel of witnesses. And Chairman, I want you to know I can't see the clock either, so because of the light. So he'll tell me. All right. I am the last one. So, Dr. Coffey, you said you have a lot of thoughts running through your head. I feel the same way. I want to make a few points, and I'd like to submit something for the record. Dr. Davis, I think your own personal story, in a way, parallels what I think is happening in our overall medical system, where you've gone from the childhood illness you talked about to becoming a cardiologist and then into functional medicine focused on longevity. And we as a medical system have focused for so long on, as you put it very, very well, I'm just repeating what you said, on treating disease after it occurs. And the results aren't very good. And in fact, I think about 90% of our total medical cost are due to these major chronic diseases, cancer, talked about that, diabetes, talked about that, heart disease, and Alzheimer's. Costs in the U.S. of our Medicare system, or medical system, to be massive compared to even other countries, and our population is sicker. So it's not working, and we're on the cusp, I think, of real change to the medical system that you're all talking about. And that is, we now have a medical system that is starting to learn about the microbiome, as you had talked about, and its impact, about our immune system, about inflammation and what that does to disease, about environmental toxins and the impact. And we're, I think, now have available to us all of these new treatments that we're in the infant stage of, but it's going to dramatically change both lifespan, both the health of individuals as they get older. And in fact, there's what I'd like to introduce to the record, Mr. Chairman, is a study by Deloitte that was done just recently, and it found that, well, I'll read it. It says, Deloitte research shows that disease prevention investments could boost health and longevity, help secure Medicare's future, and cut U.S. medical and drug spending by $2.2 trillion a year. To Mr. Bean's point, I think about the debt. I mean, this is a major driver of our annual deficit. And so not only can people be healthier, but we can save trillions of dollars at the same time. Mr. Chairman, I'd like to submit that to the record if I may.
Yeah, without objection, so ordered.
Thank you. Dr. Davis, how much time do I have there?
You got a minute 40.
Oh, I got a minute 40. All right. I think the way you framed it is really important, and that is that today these treatments we have are accessible if you've got a lot of money, and you're able to put the money into it. Like, people can go to your treatment and others and get IV and can get lots of longevity treatments, we can do things with plasma and all of these. And I think the real challenge, and it is a moral question, I think, is how do we take that and extend it to the general population who may not have access to that treatment now, and that we're learning that really can can work and could begin to address some of these chronic diseases that we have. And all of you are doing great work in this area, but I don't know how to design a system. What was really, and this is what we got to figure out. This is a big challenge. But what was really fascinating, I think Dr. Rekas and Mr. Darius, you talked about individuals being afraid to take the preventative or the diagnoses, essentially, because either, I don't know if it was because they're afraid of learning about an illness they might have, or if it's more, as you both sort of mentioned, it's potentially about the concern about the cost. So isn't that kind of amazing that, like, our system is designed not to accommodate what we know works. Like, literally, we don't pay for a screening that could prevent long-term costs for that individual or for the system. So I don't know, like, maybe if, I don't know, I know I don't have much time, but I'd love to maybe get a little bit of your thoughts on maybe a reaction to that. How do we change the system to incentivize that kind of prevention rather than the chronic disease, the system that we have now? Maybe Mr. Rekas, if you just want to address that.
Yeah, I think it's a tremendous question, and we could look at other industry. You know, we look at like automotive insurance, for example. If you go a certain period of time without getting in a wreck, your premiums go down. Why can't we have a system where if our patients are doing the right thing, seeing their primary cares early, getting their screening tests, getting their CT scans if they're a smoker, getting their blood work that can help guide the direction, that we can't incentivize them by either decreasing their copays or by decreasing their premiums? We have to help the patients do the right thing. And I think by controlling the money and looking what other industry has been able to do successfully, it could help.
Well, I know I am out of time, but I think that is the question. Why can we not have this in place? And we should be working with all of you and many other experts around the country to figure out how we can do this and to really address the medical system and change the medical system to make that care accessible to everyone. So thank you so much.
I was going to say, but I do want to put it out there because we've talked about it quite a bit. We're just about done too, which is nice. But as someone that's been in business, my wife's here for 50 years. For the first 20 years, we paid for all our employees 100%. When something that does not get recognized. Today, I hate to say it, but in our operations and others, let's say a family of four is 1,500, they're picking up 500 to 750 themselves where they never had to. So it puts more strain in terms of how far their paycheck goes. And I just kind of throw it out. And you know, the other thing, as I mentioned earlier, is we all do need to take some responsibility and be the CEO of our own health. There's not enough money to go around, and that can make a big difference. And the thought we also kick around is the idea is we've got to get real food, whatever that means, because there's a lot of trickery and all that stuff, no more sugar. But we need to really have people drive themselves to make better decisions when they go to that buffet table, to make the right decisions of what's real food and what's not. Okay, with that, I would like to thank all of our witnesses for appearing today before us and sharing your personal stories. Please be advised that members have 2 weeks to submit questions to be answered in writing. Those questions and your answers will be made part of the formal hearing record. And with that, the committee stands adjourned.